We're now going to move on to the cervix, and I'm delighted that we have Antonia Testa with us. Antonia, I'm sure most of you know, she's professor at the Gemelli Hospital in Catholic University in Rome. And I think, unfortunately, Antonia can't be with us. However, we've all met Francesca Moro, who is also works at the Gemelli, who does a lot of work on cervical cancer as well. I think this is a very important talk. Cervical cancer is a big issue, obviously, in low-income countries where maybe staging is not so easy. We don't have, cross-sectional imaging and so on. So I think this talk about potentially staging cervical cancer, I'm very interested to see what we hear. And maybe, Ahmed, you can drive some discussion around this because I think it's highly relevant. So I'm going to hand over to Antonia and we'll take it from there. Thanks, Antonia.
The evaluation of cervical cancer using ultrasound. After 10 years experience in obstetrics, I started working in gynecological oncology department, and I was so surprised at that time when I realized that uterine cervix could be assessed on ultrasound. In actual fact, even with no sophisticated ultrasound machine, the cervix is visible, is detectable on ultrasound. This is a very old image. We can see a normal cervix, we can recognize the cervical stroma, the anterior lip, the posterior lip, the cervical canal. And on the right, with the same machine, this small cervical cancer can be visible, can be recognizable as a hypoechoic lesion. What is the smallest tumor size identifiable by ultrasound? The smallest size has not yet been definitely established. However, in some studies in the literature, we can find that lesions smaller than 1 centimeter are difficult to detect, but larger than 1 centimeter can be detected, like in this case. So a small lesion there, and this was 13 millimeters. Cervical cancer usually appears as hypoechoic lesion growing within the cervix. Rarely it appears isoechoic and very rarely hyperechoic. So we can look for this type of lesion. This is the corpus and this is the lesion. The tumor can be mainly exophytic, like a mushroom on the cervical surface. This is the uterus, this is the cervix, and this is the tumor. The tumor can be within the cervix, like in this patient, and the cervix infiltrative tumor. At color Doppler examination, cervical cancers are usually very vascularized. And here you can see 3 examples. So, color Doppler helps the examiner to delineate the borders of the lesion, like here. And now let's look at some correlations with the macroscopy aspect of the specimen. We can see here the cervix, here is the lesion, and we can see not so richly vascularized in this patient, and then here we can see the corresponding lesion on the posterior lip and inside the cervical canal. And this is another example. This is the cervix, this is the hypoechoic lesion, and this is the specimen. Let's move on now to the staging of cervical cancer. Until 2018, cervical cancer staging was based on clinical examination, with the understanding that since a tumor is more prevalent in developing countries where advanced sophisticated diagnostic imaging techniques such as magnetic resonance and PET are not always available, staging was established clinically and therefore uniformly worldwide. In 2018, the possibility to incorporate both imaging and pathological analysis into staging was introduced. and therefore stage 1B3 and stage 3C were added to the FIGO staging system. Nowadays, international guidelines for the management of patients with cervical cancer included in the diagnostic workup magnetic resonance and endocavitary ultrasound, transvaginal or transrectal, if performed by properly trained examiners. Clinical assessment supported by other imaging modalities like magnetic resonance, CT, PET-CT may be used to determine local, regional and mainly distant disease. It is important to keep in mind also the prognostic factors highlighted in the ESGO-ESTRO-ESP 2023 update. And we can mention the most important factors. TNM and FIGO stage, then nodal involvement, HPV status, depth of cervical stroma invasion, and minimum thickness of an uninvolved cervical stroma, the margin status, lymphovascular space involvement, and of course presence or absence of distant metastasis. The crucial point in cervical cancer staging and management is the distinction between early and locally advanced disease. For early stage tumors, it is essential to assess the feasibility of fertility-sparing treatment in fertile age patients. The key parameters are tumor size, the distance between the tumor and the internal uterine os, measurement of tumor-free stroma. Let's look at this image so we can measure the diameters. We can measure the distance between the tumor and the internal uterine os, and tumor size has to be less than 2 centimeters, the distance more than 1 centimeter. The stromal infiltration must be less than 2/3. We suggest measuring this parameter cranially to the level of the vaginal fornices. So this is the exophytic part. Let's look cranially and we can measure the distance, the thickness of infiltrated stroma. So here less than 2/3. Fertility sparing treatment requires a strict selection criteria, so like squamous cell carcinoma or HPV related adenocarcinoma, negative lymph nodes, tumor size, tumor dimensions, and this topic is well detailed in these ESGO, ESG and ESG guidelines 2024. The accuracy of ultrasound in detecting the lesion and in assessing the extension of the disease was tested, was investigated in these studies, and the accuracy of ultrasound resulted to be similar to that of magnetic resonance. And so we compared that the predictive values are similar. However, this is the topic we are continuously working to improve. In particular, during the years, Daniela Fischerova has been of great value. She described in this beautiful paper how to analyze the tumor using ultrasound techniques, how to assess the extension of the disease, how to assess the lymph nodes. Additionally, in this work, Daniela Fischerova and Sabo, they illustrate how to assess the pelvic side wall, another very important consensus. Let's now proceed with the ultrasound assessment of cervical carcinoma. As previously mentioned, ultrasound allows visualization of the tumor and the growth pattern, then the assessment of stroma infiltration, the measurement, and the extension of the disease. So when studying the pelvis, we divide the area, the parameter structures into anterior, lateral and posterior parameter. In order to explain the different compartments, I will show on the right the image of a normal situation, on the left, on the right, an image with a patient of cervical cancer. Anterior compartment. We can assess the vesicouterine septum, can be simply assessed by pushing the probe against the bladder, like here. We can push and we can see that the vesicouterine septum is normal. In this patient, the tumor infiltrates the whole stroma and infiltrates the bladder wall, clearly visible in this patient. How can we assess the lateral parameter? In this normal patient, we can see this is the ureter. So from the longitudinal section, we can rotate the probe 90 degrees and we can scroll the cervix and we can see here the uterus. This is the pelvic wall, and so this is the section of the ureter, so we can assess this lateral compartment. This is with the color, so the section, the cervix and the pelvic wall. And this is a normal patient. Here again a normal patient. Now I'm rotating the probe and now I'm scrolling caudally the cervix. So we can see dorsally and laterally. This is the stroma, this is the vaginal fornix, and now I can go back just to show you a normal transverse section of the cervix. Here, let's start from the longitudinal section. We can see here the bladder, this is the tumor, we can see obliteration of the vesicouterine septum, but additionally, when we rotate the probe, we can see that there is an evident infiltration of the lateral paracervix. The compression or the infiltration of the ureters can determine hydronephrosis. But let's look at this grading of parametric infiltration as presented in this paper by Daniela Fischerova. So we can divide the parametric infiltration into grade 0 when the pericervical fascia is intact, grade 1 and 2 when there is a disruption of the pericervical fascia, or grade 3 with a nodular infiltration, or a clear discontinuous parametric infiltration, like in this pictogram. As I said, the infiltration of the ureters can be determined by the enlargement of the cervix, determining hydroureteronephrosis. Finally, the dorsal compartment. Again, this is a normal cervix, this is the vaginal wall, this is the rectovaginal septum, and this is a normal condition. In this patient with cervical cancer, this is the uterus, this is the cervix with the tumor, I am extracting my probe, and here I can see a nodule at the level of the rectovaginal septum. And of course, it's quite easy to check the kidneys and to check for eventual hydronephrosis. So we can see the obliteration, the infiltration in the pelvis, and transabdominally we can assess the kidneys. As we know, the cervical tumor has lymphotrophism with the percentage of non-metastasis which increases with the FIGO staging, so we have to keep in mind these numbers. Can we assess lymph nodes by using ultrasound? Yes, we can. weaker, but we are aware that specificity is very, very high. This is the visualization of the external iliac vessel. This is the ovary, and these rounded hypoechoic lesions, like here, correspond to metastatic lymph nodes. So specificity is very high, but unfortunately sensitivity is low. And here we can see two images of transabdominal evaluation. This is the aorta, the inferior vena cava, and this is the metastatic lymph node. There are ongoing studies on these issues, as I said, in particular this one, CANES, for the assessment of lymph nodes in patients with cervical cancers, and data are coming. And there is also another study ongoing in our institution with the accuracy of ultrasound in patients undergoing pelvic exenteration, just to share with you some ongoing studies. And this one is particularly focused on the assessment of the tumor-free distance, so comparison between magnetic resonance, ultrasound, and histology to predict this tumor-free distance. To conclude, before concluding, I want to share with you one issue regarding low-income countries. We know that in these countries incidence is still so high, and diagnostic and therapeutic resources are severely limited. One experience I want to mention is this one in Blinder Center in Malawi. As we said, cervical cancer is highly prevalent in Malawi, so Medicine Sans Frontières, in collaboration with the local Ministry of Health, has developed a specialized cervical cancer unit where patients with cervical cancers are treated. Extensive vaccination educational programs are ongoing in school and community areas. Suspicious cervical cancer lesions are referred to the outpatient clinic. After pathological diagnosis is made, so after biopsy, patients are sent to surgery, follow-up, or oncology team. And then additionally, there is an important palliative care, taking care of patients that are not suitable for treatment. And this group are able to reach very remote areas of the district. 2 local surgeons have been trained by high specialized European gynecological oncologists, and now they are autonomous in the surgical treatment of cervical cancer. So in this region, one of our colleagues spent a period and to share with them ultrasound examination. So we understood that it's so relevant to use ultrasound examination in these areas exactly because the management can be accurately established on the basis of ultrasound images. So to differentiate early stage cervical cancer and locally advanced, because for these patients surgery is indicated. Here only radiotherapy is indicated, but if radiotherapy is not available, chemotherapy. Recently, with an international working group, we developed a toolkit aimed primarily at those developing countries lacking magnetic resonance and radiotherapy facilities. And in this toolkit, we decided to describe how ultrasound can assist in staging and managing cervical cancer patients. Specifically, based on ultrasound, we classified cancer cases suitable for surgery, for neoadjuvant chemotherapy plus surgery, and those available only for upfront exenteration or only palliative chemotherapy. So this is just been accepted for publication, and now we are ready to go on with a project, an interventional project. So to conclude, we do believe that cervical cancer can be examined on ultrasound. It plays a key role in the diagnostic workup to assess fertility sparing criteria for fertility sparing surgery, and new frontiers can be explored in collaboration with other specialists to delineate the best management in all around the world, mainly in low-income countries. Thank you very much for listening.
Yeah, thank you, Professor Antonia Testa, for this excellent presentation. I think we have some questions. Oh, hey, how are you? I thought you're not here. Very good
Fine,
to see
thank
you.
you. I could
Very
join.
good.
I hope
Very
you
good to
can
see
hear
you.
me.
Yes, very
Okay,
well.
good.
Very well. So let's start with the questions from the audience, if that's right. There's one interesting question. What should we do next step? And this is, I think there was a question from Manal, but it's taken away. But Sausan asked question, after finding of an irregular cervical mass with a high vascularity, what is the recommended imaging modality for staging, in your opinion?
In my opinion, as I tried to explain in my lecture, it's possible if you are well prepared, well trained, it's possible to complete a staging, local staging with by using ultrasound. Of course, if you have the possibility in your center, in your country, you can perform magnetic resonance because you have a complete an overview, a panoramic imaging. So that's my answer, simply.
Excellent. I mean, there was another question, I think it's been taken away, but I still want to, it's still here actually. Since most cervical cancers are diagnosed clinically, what specific findings we should see on the ultrasound scan to avoid false reassurance from normal ultrasound scan? I think, yeah, I think there may be there to I don't know. There's a stage of microscopic. I don't think ultrasound scan is useful when it is that early. We're talking about microscopic, but I really need to see what you think as well.
Yeah. So we have to keep in mind that for years, staging for cervical cancer was only based on clinical examination. And this was important because this was the only way we could share all around the world a similar staging, and mainly in countries with economical difficulties, they have no possibility to have sophisticated imaging, right? So now, of course, the strongest message is let's do clinical examination. Let's look at the cervix. Let's take biopsy. Let's try to get all the parameters we can with clinical examination. But then, of course, if we wanted to check the parameter infiltration, if we wanted to check the ovaries, if we wanted to check the local spread, we can use ultrasound, simply.
I agree.
And in the end of my lecture, I showed this toolkit. I hope that it can be useful. We would like to spread it all around the world, and to give our colleagues the possibility to use it, to test themselves after an appropriate training, of course, because
Excellent.
they
I
can
mean,
play an
yeah,
important role. Please.
excellent. One final question from my side, just low income country, okay. Can we, from your opinion, what is the minimum package for imaging? Let's say a patient who's come in for stage, with this early stage, will you do ultrasound scan, vaginal, abdominal, and simple X-ray or CT chest for the? I don't know. What do you think the safest, cheapest, cost-effective way in low income countries?
Sure. We demonstrated that people can be accurately treated for performing a radical hysterectomy. So, as if we have good surgeons, accurate surgeon, to plan an accurate triage between early stage, advanced stage is fundamental. So you can start, you see distant metastasis, and you have a biopsy positive for cervical cancer, you know what to do. If there are no distant metastases, you concentrate there, and you can decide local, advanced. And then you will plan your good management, good treatment.
Okay.
So we really hope to be able to make a change.
Excellent. Professor Bourne, any questions? I can't see any questions from the platform.
I don't think there's any more questions for you there. Where are you, Antonia? You're in the middle.
Oh, greetings from Paris. I'm
Paris.
here
Oh,
working on guidelines within a multidisciplinary group for oncological patients.
I could just like, it's like a huge hallway.
Yeah, yeah. Perhaps some music also. I tried to be in a quiet place, but
no, we can't.
always different.
Listen, Antonio, thank you so much for that. Really important
Thank you.
talk, I think, for
Thank
this
you so much.
audience who really, I mean, also it'd be interesting to hear how you can roll this out in terms of training and whether partnerships with people like ISUOG or others would be one way of doing it, because obviously it's quite a hard thing to do. But I mean, at least Ultrasound Essentials will get people knowing that it's possible and starting to investigate whether to do this. If people want to learn, though, can they get in touch with your group or not? If they're in
Yes, of course,
Right.
of course.
Okay.
But we will try to reach out all of you and to involve you in a big, big project.
Oh, no.
Oh.
Not another one, Antonia. Thank you. Thanks so much. Have a good time
Thank
in
you.
Paris.
Bye-bye.
Bye
Take
now.
care.
Bye-bye.
Bye-bye.